I think we're just missing Joe. There he is, Joe. Hi, Joe. All right. Good morning, everyone, and welcome to this session on the lived experience of healthcare, a global reality. My name is Jonathan Birdwell. I am Global Head of Policy and Insights at Economist Impact. Economist Impact is the in-house think tank of the Economist Group, which is, of course, publisher of The Economist. I'm sure you're all avid readers and subscribers of The Economist. And I'm very pleased to be moderating this session today. At Davos, we're very good at kind of discussing systems and spending and technology and all of those sort of abstract, very important, obviously, institutional questions, but can often feel disconnected from the sort of lived experience, right? And so for this session, we wanted to bring the, I think as it's framed, the sort of kitchen table conversations that happened around healthcare, because there's such a disconnect. Everyone, literally everyone, can relate to the lived experience of having a concern about a potential health issue, being able to access or not, being able to afford or not healthcare. That worry, that concern, whether it's for yourself or a member of your family or a friend, everyone can relate to that. And yet, so that's the kitchen table. But then when we take it up to the policy level, things get pretty complex pretty quickly, right? And that disconnect can feel, I think, pretty bewildering for a lot of people. And so how can we kind of bring that lived experience to the policy world, and sort of, I think you need to have a conversation kind of back and forth, right? To keep tweaking. How do you, where does the policy not meet the lived experience? What lessons can we take from the lived experience and apply it back to policy? How does this manifest across the world, right? Whether it's sort of global north countries or global south countries. There's a lot I think both can learn from each other when it comes to system design, but also improving that lived experience and access to healthcare. So to talk about some of these topics, very pleased to be joined by a fantastic panel. Immediately to my left, Grace Matthew, Managing Director of We Think, an impact advisory firm. To her left, Manira Alva, Senior Advisor for the SDGs at Vital Voices, a global NGO focused on women's leadership, empowerment, and policy advocacy. To her left, Tim Lash, President of the Gary and Mary West Foundation, the West Health Institute, and the West Health Policy Center, collectively focused on philanthropy, policy, and research on U.S. healthcare. And then to his left, Joe Daly, Global Managing Director of Gallup's Public Sector Group. And of course, Gallup, everyone knows, the American polling firm best known for its long-running public opinion surveys. So maybe Joe and Tim, I want to come to you first, because I know West Health and Gallup have had a kind of long-running partnership where you've been studying perceptions of access to healthcare in the U.S., and I believe you've been doing this for a number of years now, and so have some really interesting kind of longitudinal data, but you, of course, have a latest iteration of that, too. Joe, maybe can I come to you first and just give us a little bit of a high-level picture of the data, right? What are you gathering, and what's some high-level findings that are emerging from that?
Thanks. Hi, everybody. Welcome to the Wednesday morning show at Davos. No,
Thursday.
Exhausted. Thursday morning? That's my point. Maybe it's just me. Anyway, yeah, so really excited to be on this panel and talk a little bit about the work we've been doing with West Health. So Gallup has been in, obviously the business of asking Americans primarily for about 90 years just to tell us about their lives. And of course, their health and how they experience the healthcare system is a really, really important part of that. So we have some decent trends that go back 30 years that are high level, just asking about satisfaction. We had the opportunity to partner with the Gary and Mary West Foundation about 6 years ago, just on the premise that there's not enough focus and there's not enough data on the actual experience of Americans and how they're experiencing healthcare. Healthcare is a very complex, highly regulated industry in America. So I think a lot of times you end up with hyper experts who really care deeply about the subject, arguing with each other about what the implementation model should be, And the problem is that you just kind of leave the American out of the American that's experiencing the system out of the equation. And so I think, like, if you're trying to distill, what are we doing? I think we're trying to elevate the voice. We're trying to elevate the experience of Americans, and we're hoping that by putting that front and center to policymakers, to experts, that we sort of start there with what's the problem, what's the experience, so that these really good, highly expert people can then apply all that good thinking to the right problems, and so that we get the right outcomes in its simplest nature. So we started with some national level research, but I think one observation that we had was, if you think about all of us, we think about the way we experience healthcare, it's experienced at the local level, at the community level, at like literally the individual person. And so what we're endeavoring to do is to not only bring the lived experience forward, but then try to granularize it as far as we can. So this year, we created the first launch of a state-level scorecard for the lived experience of healthcare in America. Specifically, we're trying to look at cost, quality, and access, and just asking Americans, how do you feel about all of those things? And so some really, I would say, kind of alarming things that we've seen in the data are that like almost half of Americans are basically saying that they're struggling with cost. You can see in the data very clearly that people are delaying getting the care, especially maybe the preventative or even the small things, because they're not able to afford that. And so we're tracking, and again, the scorecard would say overall not a very good one. We're averaging in the C. We do it by A, B, C, D. We're averaging about a C across that, but then we can start to pull it apart and see which states are doing really well, which aren't, and we're hoping that there could be some sort of community of practice that develops from it. So you say, okay, hey, Iowa and Massachusetts, you scored remember, it's a C, but it's relatively well. What are you doing that's great? You got a fairly rural state and you got a fairly urban state, so there's a great conversation that can emerge from that. And so that's what we're up to. Yeah.
Does anyone get an A?
No.
B?
No.
Okay. Right. Okay. Oh dear. Thank you for that, Joe. And Tim, can you maybe say a little bit about how West Health sort of uses this data, right? Are you using this to engage with policymakers and try and kind of get policy change as a result?
Sure. So now that Joe told me it's Thursday, maybe we reflect on Wednesday. If we think about Wednesday as the modern era, and we think about what has happened in healthcare, right, and the advances, it all happened between 8 and midnight last night, right? I mean, like when you think about sort of the broader scale, right, of progress, and in the global north and in the global south, I'd say a lot of that progress has really been achieved, right, through science, bleeding edge innovation, whether it's in the south with malaria, addressing malaria, here, in the global north, we have CRISPR, and that really has sort of bent the curve, right? But as we look moving forward, I think globally, the opportunities really are the lowest hanging fruit, which may have been science before, really lie in the delivery, right? How do we think about addressing the discontinuity in the system, right, and aggregating the assets that we have? And if you're going to do that, I think you really do need to understand how is it really for individuals, for their families, for their communities, globally. And that, then that data, right, can then really inform the priorities in terms of what are people paying for, and what do we need to change, right, in terms of the system, and how can we learn, right, globally, right, in terms of what's working and what's not, right? And so at West Health, we advanced a number of initiatives. We call them accelerators. We're integrating behavioral health with Northwestern, technology with MGB to hardwire and reduce variation of care. But that all is based on a fundamental understanding of the struggles, right, that the communities are facing, and then looking for what are the leadership changes, what are the delivery changes, and then what are the incentives from a policy perspective that can ultimately drive that. And I think while the lived experience, I think in Wednesday for the entire day really should be, grounding all of the work as we start to move from bench science and just sort of innovation and bleeding edge innovation to the things that, sort of really translate directly, right, to the experience and the continuity within the healthcare system. There more than ever, you really need to ground it, in the perspective and priorities of the community.
And do you find that that's important to kind of get the attention of policymakers and decision makers, right? Is it enough? Do you need to kind of show them, literally as you've done on your hub, videos of people talking about their own experiences? Is it the statistics no longer sort of move policy action?
I think you have to move the heart and the mind, right? And that's really where, the statistics, when you humanize them, right? And the science, when you humanize it, and then you can capture that in a story, you can make progress that probably would not be possible otherwise, at the local level, at the state level, and certainly at the federal level.
And Munira, I want to bring you in here. You do a lot of work in India in particular. You maybe talk a little bit about your work and your experience and the lived experience of those you work with in terms of access to health.
Absolutely. So I'm going to be a little controversial and say there's a little bit of the global north in the global south and a little bit of the global south in the global north. Both our geographies have the 1% who have access to everything and that huge percent who is struggling to just get basic stuff and to believe healthcare is a right more than a privilege. Having said that, I also think it's a moment where the local should be going global. We're seeing some phenomenal stuff happen in India, centered around human-centered design, where healthcare and solutions are being designed for communities and they're being met where they are. So mobile medical services are gaining ground. Rather than someone having to move miles and miles to come to healthcare, healthcare is reaching them. We know India is booming in terms of tech and AI, so there's a lot of integration happening there. And what is most inspiring is the role the social impact venture capitalist is playing. Someone who's really interested in driving change, especially in rural India and to marginalized communities. We have a chain of hospitals called Cure Bay, which is doing phenomenal work, and in fact, Latin America and African countries are coming to study what they are doing, which is really meeting rural communities where they are with some of the best healthcare services. From our network, we have a lot of women working on healthcare. From Africa, we had, I'm sorry, I'm missing the name, but she set up mobile clinics in marketplaces for women because she knew women came, she knew the timings they came. So for preventive health, she set up these mobile clinics and was able to help them. So there's stuff like that that's happening, and it's really a moment of disruption as well. And we're hoping that both of us from both our geographies can share a lot of this stuff.
Yeah, I'm very interested in the potential for technology to change the lived experience, really. Just, making it more convenient, as you say, sort of meeting them where they are, people in where they are, rather than making them travel and sort of access on the terms of the system. How much, maybe anyone else can answer this, how much do we think, like over the next 5 years, as we see progression of wearables, will we start to see a fundamental change in the data of people saying, well, actually now I can access, access more self-care, I can access healthcare more easily, and therefore my experience is much better?
I think one of you guys.
I can jump in there. At this meeting, there's been a lot of discussion around leapfrogging, and if you look at cell phone utilization, in the developed world, in the global north, we've had the plain old telephone service, the copper lines, right, and then eventually fiber, et cetera. And you look at the global south, that never happened. You just, everybody has a cell phone now, right? And so you had a blank slate, and then we leapfrogged over from a technology standpoint. And if I think about healthcare, the global south in many ways has been exploited by the global north. I used to work for Johnson & Johnson, and many trials were done in the global south because it lacked the regulatory constraints, financial incentive. There were a lot of reasons why it made sense for a for-profit company to accelerate things, to do it there, right? But when we think about sort of moving forward, there's, I think, opportunities to take what we've learned, from the global north, right, and have opportunities to not repeat some of the mistakes that have been made and sort of leapfrog over. And from a technology standpoint, I think globally we need simpler solutions, algorithms that can help stratify populations, that can target, sort of interventions, that can, just make it more efficient and reduce the variability. And so as I think about the role of AI or telehealth or EMR or any of these things, my hope would be that the global north has proven to had been exploited, in the other direction, and that a lot of sort of dollars have been spent, and lessons learned and potholes that we've fallen in, and that we can leapfrog over to the global south and deploy some of those learnings and those technologies in a more efficient way.
Grace, do you want
Yeah, I might just add a comment. I think to the earlier comment, the stratification of healthcare access is much more along economic lines rather than geographic lines. And so in a place like, for example, India, as you mentioned, there is a very, very wealthy population, wealthier than what you might encounter on an everyday basis in America. And so their access to very deeply individualized, personalized care is going to far outstrip people in the US or even in Australia, where I'm from, which is in the global south, but not really the global south in the manner that we're talking about. So I think that's something to take into account when we're talking about how technology adoption, particularly individual technology adoption, can change the outcome of care. Because really what that comes down to is the individual having access to their own healthcare data and knowing how to then use that to access services. I think one thing that perhaps has needed to happen in the global south is more of a community-based model of care. And I also think the depoliticization of healthcare in places where healthcare is just a basic need, as opposed to where it's a luxury that has a system that has sort of leveraged it just to create great financial outcomes. And I think that's one of the failures of capitalism, to sort of take it to a high level. It was never supposed to create a public good like healthcare, and the kind of ubiquitous access that's needed for people to have a flourishing society. And so I think having, as we have in Australia, for example, like a base level of free access to healthcare across, no matter who you are, or as long as you're an Australian citizen or permanent resident, and then having an outcomes-based model of payment or reimbursement, for the provider, which I think has transformed outcomes. So rather than it just being, the incentivization is to give the individual more prescriptions and more surgeries and more of these sort of higher cost interventions. Instead, the actual incentivization is to create better outcomes for the individual. And I just also want to mention in terms of, because your question was also about data. Some of the largest longitudinal studies were the Finger and Singer studies, which in Singapore, when they tried to start the study, they needed the population to adopt wearables. And initially, the population was very reticent to give the government access to their individual data, with good reason. But as soon as they said, look, if you give us access, you'll get a free Apple Watch or a free wearable, all of a sudden everyone was signing up. Yeah. And so I think particularly when the barrier to entry for higher level care is just a basic cost, if a great way of intervening and making that again more accessible is just basic financial incentivization.
Yeah, absolutely. And I do want to come back to the community point too, because some of our research as well, it shows that that's one aspect where in the global south, the sort of strength of community-based care seems much, much stronger than in countries in the global north. But before I do that, I'm just checking, because we do have a very illustrious guest who has just arrived, Dr. Tedros from, of course, Director General of the World Health Organization. Dr. Tedros, I don't know if you're ready now, but I believe you have some remarks for us. Okay. Well, without further ado then, Dr. Tedros, please come up in the floor. Okay, he's being mic'd up. Okay. Well, maybe just while that happened.
I only have 4, so I have to steal them. Thank you very much.
Maybe just while that happens, just on that community point. I mean, is that your experience, Manira, working in India? Yeah.
100%. I think it's also cultural. India and the big fat joint family system which never breaks. But apart from that, it's the community, right? And we know it takes a village, it's often said, but you really see that up close and personal. In fact, right from the time a child is born in rural India, you have something called the Asha nurse, who is given a kind of equivalent to what we talked about, a blue zone, like she's given a certain periphery, and she visits those homes all the time, whether it's immunization, if something's happening with the mother, the child, you know, there's someone that they can talk to right there, there's relationship built, and there is trust where they're ready to discuss, you know, anything that's happening. I think that has been one of our strongest systems, and that then goes into early childhood education. The same nurse will ensure that that child is registered. Then she goes into the next phase where they get, you know, midday meals and all that kind of stuff.
Yeah.
So I hope that stays. Of late, those budgets are being cut very gently and being rearranged. And I think there will be a whole other set of crises if that actually happens.
And that might be an opportunity if we talk about leapfrogging, right?
Yeah.
So technology coming from the global north to the global south and leapfrogging. We really don't, you know, we don't leverage the community at all for the most part, or we don't leverage the community in the global north. And so if we think about what we could leapfrog coming back up, thinking about how we think about, you know, community health workers and integration, right, of the broader community fabric, I think there's a lot of lessons learned that can be extracted from what is, you know, a necessity, right, you know, in the global south to something that is also a necessity in the global north, but not necessarily incentivized from a financial or payment perspective at this moment.
I might just add a comment that particularly when it comes to governments looking forward at the rising burden of healthcare costs becoming unsustainable, particularly when you see, you know, the incidence of things like a COVID or an outbreak of sort of what should be an unforeseen circumstance, but is going to happen again. Governments have to be prepared for this, and the hospital-based model of care is going to be unsustainable as the rising costs of healthcare and as as healthcare issues become more and more widespread throughout the community. And so that's where you see technology bringing care back to the home. And I think that's also where we will need to see, again, something that the global north will need to adopt from the global south, which is having healthcare leaders or sort of nodes of care embedded within the community, enabled by technology, and also potentially the incentivization of innovation rather than just research. So at the moment, universities are incentivized to publish research. We need to incentivize outcomes. We need to incentivize patient outcomes, which means like there's a systematic and systemic change that needs to happen.
I just want to add here and kind of sound a warning bell. As we discuss healthcare moving into the home, that's the added burden on care work, and we know where it is going to end up. And that could be self-defeating too. So we have to respect specialization of services, and there have to be spaces that address them, because otherwise everything from education to healthcare to everything is collapsing in the home, and that's going to have a whole other crisis.
Right. Okay. So I just checking to see if Dr. Tedros, are we ready here? Dr. Tedros, are you ready to come give your remarks? Okay, great. Well, please, Dr. Tedros, without further ado, come up. We're very, very pleased to have you here. Of course, Director General of the World Health Organization. I think you're going to say a few words and. Oh yes, please.
Got a separate sound system.
Do we stay or do we go? Okay.
So we're delighted to have Dr. Tedros here this morning. My name is George Vredenberg. I'm the founding chairman of the Davos Alzheimer's Collaborative, founded 5 years ago with the mission of connecting developments in the global north and the global south around brain health. And as a consequence, our mission is totally aligned with what the WHO stands for and what Dr. Tedros is leading so effectively. So we started last year with an idea. This year it's turned into a movement, the attention of and the importance of the brain to our social and economic development around the world. In the United States, yes, but the rest of the world, yes. We now have brain health plans in Africa, and there will be ones in India and Latin America soon. But Dr. Tedros has been leading the World Health Organization effectively now for years in a very turbulent environment, and nevertheless he has led effectively, well, and with broad perspectives on the importance of global health to everyone's health around the world, as well as to the global security associated with healthcare. So it takes a great delight from the Brain House to be able to introduce Dr. Tedros for a few remarks. He has very important discussions going on. I'll have to leave immediately after his remarks, but we're so pleased that he was able to carve out a little time for us, Dr. Tedros, this morning. Deeply appreciate that. And my great friend and partner, Kerry Kennedy here, who has introduced me to Dr. Tedros, to my great delight. So thank you.
Thank you. Thank you. So I would prefer to address you standing. Thank you, George. And also thank you to Kerry for connecting us, my friend Kerry. And good morning, and it's an honor to join you all. Not working?
I think for the camera.
Yeah, you need both.
You need it
for
for the
the camera.
recording. For the recording, yeah.
Okay. And again, my sincere thanks to George and Davos Alzheimer's Collaborative for the invitation and for your leadership in building a global movement for brain health. Last year I was supposed to be with you, but I couldn't because last minute I had to go to Tanzania to help Tanzania on the Marburg outbreak. Of course, they contained it quickly. So that's why, but it's a great honor to join you this year. And just last week, I had the honor of being in Paris to speak at the World Brain Forum to mark the 15th anniversary of the Paris Brain Institute. So it's very encouraging to see how brain health is being elevated into global health agenda. And rightly so. The brain is the most complex organ in the human body, but the least understood, as you may agree with me. It's the command center of human life, the source of our thoughts, our memories, our emotions, our creativity, and above all, our relationships. The brain is the engine behind humanity's greatest achievements, but also its greatest failures. It makes us who we are as individuals and as a species. Brain health is increasingly recognized as a foundational pillar of human development, economic growth, and societal well-being. And yet, despite its central importance, and despite the huge burden of disease, brain health has been historically overlooked. Today, neurological conditions affect more than 40% of the world's population and cause over 11 million deaths each year, with the largest care gaps in low and middle-income countries. And as George said, that's why we have to support the developing world. In addition, nearly 1 billion people suffer from mental health conditions, which are often linked to neurological disorders. Demographic and environmental pressures are intensifying these challenges. Aging populations, hypertension and diabetes, pollution injuries, and climate change are driving a sharp rise in neurological conditions. Women carry a disproportionate share of this burden. They face higher risk of conditions such as dementia, migraine, and multiple sclerosis. And they also shoulder the majority of caregiving responsibilities, formal and informal. meaning the impact of neurological conditions is multiplied through a gendered, economic, and social inequities. The cost of dementia alone illustrates the scale of the issue. Up to half of global dementia costs are attributable to informal care. That's why WHO's Global Dementia Action Plan calls for 75% of countries to provide dedicated training and support programs for carers. However, according to the Global Dementia Observatory, only 24% of member states currently offer such services, 24% of the 194 member states we have. Despite the enormous human and economic consequences, many countries still lack national plans, economic-based care services, or sufficient investment in research and innovation. Global Dementia Action Plan targets remain unmet. To address these gaps, WHO is strengthening its leadership across the life course. In 2022, we published a position paper on optimizing brain health, defining a comprehensive approach from maternal health and early childhood to healthy aging. The evidence is clear. The foundations of brain health are laid early, and women, especially during pregnancy and early parenthood, play a critical role. Ensuring supportive environments from the earliest stages is one of the most powerful investments societies can make. But brain health is not only a health issue, it's a whole of society issue. Investments in what we increasingly call brain capital, including education, healthy environments, prevention, and accessible care, fuel innovation ecosystems, strengthen economic resilience, and contribute to social cohesion. Brain health determines our capacity to learn, to adapt, to create, and to connect. WHO is grateful for the growing number of partners stepping forward to support this agenda. In particular, our collaboration with the WHO Foundation is enabling new models of partnership, including with the private sector, to help countries expand community-based services, integrate neurological care into primary health care, and improve access to essential medicines. I encourage all of you to connect with the WHO Foundation to explore how we can accelerate progress together. WHO also plays a critical role in shaping research priorities and setting global norms and standards. This includes the WHO Blueprint for Dementia Research, which highlights significant gaps, including the lack of sex disaggregated research and insufficient representation of women in clinical trials. We have also published preferred product characteristics for blood-based biomarkers for the diagnosis of Alzheimer's disease. We have updated our guidelines for cognitive decline and dementia risk reduction, and more. But of course, no single institution can meet this challenge alone. We need stronger partnerships with governments, research institutes, innovators, investors, philanthropists, civil society, and movements like the Davos Alzheimer's Collaborative and the Brain House community to translate commitments into action. And I thank George for his leadership on this. Our shared goal is simple and profound: to enable every person in every country to achieve their full cognitive, emotional, and social potential. If we succeed, we will not only reduce suffering and disability, we will strengthen societies. We will accelerate innovation, and we will unlock the brain capital that the world urgently needs at this moment of rapid change. Together, across sectors, disciplines, and geographies, we can transform the future of brain health for all people everywhere. I thank you. Thank you.
Thank you, Dr. Tedros, for those rather inspiring and comprehensive remarks. You've really brought everything together in one area. I want to thank West Health for allowing us to interrupt your work right here on the Vitality sessions. But thank you. I appreciate that, Tim, for all of your work. And Shelley, thank you very much for that. But Dr. Tedros, it was a delight for having. Now, go negotiate. Get us back in. Thank you very much. Back to your regularly scheduled programming.
Excellent. Thank you so much, Dr. Tedros, raising awareness, of course, on the very important issue of brain health. And I know after our panel, there will be a panel on brain health. But just to kind of wrap up our discussion very quickly, I wonder if I could just ask for some closing remarks and reflections, right? We're here at Davos, obviously illustrious and important audience of decision makers that can make a difference here. What are some of the sort of one takeaway that you would want to leave them with as we look to the future, the importance of the lived experience of healthcare? What do you think needs to happen over the next couple of years to sort of make sure that policymakers have better understanding of the lived experience and how it can feed up into policy? But Joe, from your perspective, perhaps on the research side, do we have the insight that we need on the global picture, or is there perhaps a data gap there, or any other final reflections you might have?
Yeah, I think just quickly, so Gallup has for 20 years been conducting something called the Gallup World Poll, which is we get to 95% of the world's living population every year across 140 countries. We ask them everything from their situation with their job, how they feel about the institutions of their country, well-being. But one of the questions we do ask is about satisfaction with the healthcare system. And I was looking at the data before coming on here, and I love the sort of the theme, which is there's a bunch in the north and the south. It's sort of almost silly to divide the two. We need to look across it, and we say what's going well. And so surprisingly, you see, of course, global south satisfaction is lower than the global north, but there's outliers. So like Greece is considered a wealthy country or whatever, but it's one of the lowest in the world on healthcare satisfaction. You also have Rwanda, which is at like 80% satisfaction, and it's considered global south. So I think we need to look across all of it, and I do think that thanks to West Health, we are much deeper and much more granular on the actual specifics of the lived experience of healthcare, and we only have that one headline indicator. We've done some work on NCDs or whatever around the world ourselves, but I think taking that deeper and getting a little bit more granular around the world so we can share those best practices is a big opportunity.
Excellent. Thanks, Joe. And Tim, from your perspective, a sort of final takeaway from the audience around lived experiences. Joe said, I know you've taken the data in the US down to a more local level in this last iteration. Sort of where are you going to go from here?
So I guess the lived experience matters, but we have to improve it, right? We have to actually evolve the lived experience. And so if we go with the example that I offered before, that the modern era was Wednesday of 24 hours that we witnessed yesterday, and most of our progress happened between 8 and midnight. We're heading into the global era now, right? And I think in terms of what works and what doesn't work, right, we're now just, at sort of midnight, or 1 a.m., right? And we're going to see, I think, more convergence. And the path forward is really looking at how can, again, we leverage, right, what we've already learned and leapfrog in the global south. And then how can, from a community perspective, workforce perspective, integration perspective, leapfrog in the global north. And so that we stop talking about global south and global north, and it is global health.
It is.
And then Manira, yeah. Manira, as you kind of look ahead in the next couple of years, are there any final remarks from you, but anything that gives you particular concern or worry that, those cost-desperate folks that are having a poor experience, lived experience in health, let's say in India or other places in the global south, what are your sort of concerns about shocks to the system that might worsen that picture?
I'm going to just share my lived experience. I live between Washington, D.C. and Bangalore in India. There are times I have to wait weeks for an appointment in Washington, D.C. to meet a doctor, and invariably end up meeting a nurse practitioner. In India, I might have to wait a couple of hours, but I can actually get a doctor on the same day and be treated on the same day. So it's just my lived experience, but I think it's a moment of disruption, and we really have to encourage the disruptors and just change all these systems that are holding us prisoner right now.
And then Grace, final word to you.
I think I'd echo enabling the disruptors, and I think my thoughts are probably more along the lines of, I engage and we work with some of the most significant family offices in the world and advise them on both their investment and philanthropy strategies. And so our encouragement is always to those who have the kind of patient capital that can be deployed into spaces like healthcare and technology, which create the underpinnings of a healthy society and can be used to rethink the way healthcare is enabled across the world. To really, while it may not be the lowest risk, it may require subject matter expertise, it might be stepping into an area that the family or the investment team might not be super comfortable with. But to think beyond the short term and to think more in terms of how you can both leverage technology and innovation to create great financial outcomes, but also to create the world that we want our children and children's children to be able to live in.
Yeah, excellent. So thank you all very much. I think it's been a really interesting discussion. It was great to have such a illustrious sort of guest speaker as well, with Dr. Tedros come in and present his perspective as well. And as I say, stay tuned for the next panel on brain health. But for me, I think, it's my reflection is you can design the best system, but really it does come down to that lived experience. In our own research, we saw a huge, you could have a sort of perfectly designed, inclusive system, but then when you start testing people's experience, all the scores go down. And so people feel risk, they don't feel budgets, and so we can't assume that more spending equates to better experience of healthcare. But thank you to West Health and to Gallup for shining a light on this. Thank you to Grace, Manira, as well for contributing to the discussion. Tim, Joe, and thank you all for your attendance. And stay tuned for the next panel.